So the newer cell deaths that we have to know, let me tell you, because definitely these are the questions that we expect in the paper. These include necroptosis, these include pyroptosis, and I'll touch upon something also known as pheroptosis. Also another very tiny little diagram and a tiny little definition that you have to know is anoikis. These are all the new ones. So let's start. Let's start with the first one, and that is necroptosis. Now when I say necroptosis, I want all of you to break the term. We will divide it into necro and tosis, because necro word will remind me of necrosis, number one, and tosis word will remind me of apoptosis. So yes, is this a combination? Correct. Whatever I have studied in necrosis and apoptosis, it's time to bring everything together, and now we will study necroptosis. So please remember, firstly, the definition. We can't proceed without that. So remember, this is also a programmed cell death. This is also a programmed cell death. Like apoptosis, has it got it from apoptosis? Yes, but the difference is that in apoptosis, there was a lot of caspase involvement. Do you remember caspase dependent programmed cell death? So that is the difference. What is necroptosis? Necroptosis is caspase independent programmed cell death. It is caspase independent programmed cell death. So that part of it is important. The caspase word from today onwards, remember, if the examiner has written necroptosis, it's criminal that you use the word caspase. You cannot use the word caspase at all. Remember this very, very strictly, okay? Chalo, coming back. So when we talk about what is necroptosis, it's little bit of necrosis, little bit of apoptosis. We are going to club them together. So let's see, what all are we stealing from necrosis, apoptosis? From necrosis, remember, we are stealing the morphology. We are stealing the morphology. Means, do you remember necrosis had inflammation? Yes. So necroptosis has also got inflammation. Talking about the next, that is apoptosis. What has it stolen from apoptosis? It has stolen the programmed cell death. Number 1 point. So both of them are programmed cell deaths. Also, if you remember, apoptosis was what? Physiological, pathological, or both? Both, right? So necroptosis is also going to be both physiological as well as pathological. That is what it has got in similarity to apoptosis. So give me some examples. When is necroptosis? When is necroptosis going to be physiological, normal, that is growth plate formation? When the growth plate of our body is forming, that is when necroptosis is a normal thing to occur. Where was apoptosis physiological? Quick, the most important example, remember the hand and the example that I gave you, embryogenesis or organogenesis. Over there, apoptosis was physiological. Where is necroptosis physiological? It is physiological in growth plate formation. What about the diseases? So remember, steatohepatitis. Steatohepatitis. Next, pancreatitis. It can also be seen in reperfusion injuries. And what is reperfusion injuries? These are very commonly seen, if not common, but yeah, they are seen in heart attack patients, myocardial infarction patients. When they start treatment, reperfusion is done. That is when all these necroptosis. But the two main important, steatohepatitis is what? Something like fatty liver, and pancreatitis all of us know. But now what I'm going to tell you is one of the recent advances. So the next topic is, what has Robbins 10th edition added onto the names of necroptosis? So now when I said it's a little bit of necrosis and a little bit of apoptosis, they'll say, okay, necrosis word keep as it is. Instead of apoptosis, use the word programmed. So you know what did they do? They started calling this as programmed necrosis. That is update number 1. The other name for necroptosis is programmed necrosis. After that, please remember, the latest update that has come is the update related to cytomegalovirus. What do I have to know for cytomegalovirus? Please note, so just think, cytomegalovirus or any virus, when it comes into your body, what is your plan A? How are you going to kill that virus? So you'll say plan A will always be apoptosis. So imagine, as soon as this cytomegalovirus came into my body, I was ready with plan A, that is apoptosis, that I am going to kill it with apoptosis. But cytomegalovirus is quite a smart individual. You know what cytomegalovirus has? What has God given it? It has caspase inhibitors. It has caspase inhibitors. It's going to inhibit the caspase. So now imagine when CMV enters into our body, it is going to inhibit the caspase. Will you be able to carry out apoptosis without caspases? No. If caspases cannot be used, which is the cell death? What is plan B? Plan A has failed. I can't carry out apoptosis. So plan B is I will carry out necroptosis. Why? Because necroptosis is not needing any caspase. The definition of necroptosis is that it is caspase independent. So that is a question that is asked. How do we kill cytomegalovirus? Do we kill it with apoptosis? No, we can't. Why? Because cytomegalovirus has caspase inhibitors. How do we kill it? What is plan B? Necroptosis. Okay. Having said that, the next part that we have to start with is the mechanism of necroptosis. A lot of updates have happened in this. I call it a 1, 2, 3 death. That is how I have learned it. 1 step, 2 step, 3 step death. So this is going to start when a mediator called TNF comes and binds to something called as TNF receptor. So for example, if this is a cell, we'll write it once again. If this is a cell and the cell has something called TNF receptor, who is going to come and bind to it? There is a molecule that is called TNF which will come and bind to it. As soon as this binding occurs, this is step number 1. As soon as this binding occurs, there are 3 people who are going to come and form a complex. Trio is formed. What is that trio? That trio is number 1, RIPK1, RIPK3. So what is RIP? RIP stands for RIP kinase, that is receptor interacting protein kinase. It is receptor interacting protein kinase. So RIPK, that is receptor interacting protein kinase 1, receptor interacting protein kinase 3, and finally the third one, and please don't think that I'm being diplomatic or hypocritical over here, but the third thing is a procaspase 8. Now guys, the first sentence I said, I tried to act very strict and I told you, in necroptosis mein you cannot use the word caspase. So I have stuck to it. I have not used the word caspase. What have I used? I have used the word procaspase. Inactive form. Is it ever going to get activated? No, that's the rule. This never gets activated. Is it ever going to form procaspase getting converted into caspase 8? That cannot happen. I have to be very strict about it. It is caspase independent. Yes? Okay, so step number 2 also is done. A trio is formed. What is step number 3? We are waiting for it because that's the last step. That's the latest step of Robbins 10th edition. And that is MLKL phosphorylation is going to occur. There's going to be an MLKL phosphorylation. You don't want to know the full form of MLKL. That is not important. But yeah, MLKL phosphorylation occurs, because of which finally there is the cell membrane rupture. There is cell death that is going to occur. So let's do a recap. As I told you, it is 1, 2, 3 death. Okay, so what is the first step that has occurred? The first step is the binding of TNF and TNF receptor. What is the second step? There's a trio formed, RIPK1, RIPK3 and procaspase 8. The third step, which is the Robbins 10th edition update, that is MLKL phosphorylation has occurred. And finally, there is cell death that takes place. Well, that marks an end to the newer cell death, that is necroptosis. The key events over here, it is caspase independent. Number 2, the new update, where does MLKL phosphorylation occur? That is in this cell death. And number 3, which virus is going to be killed by this cell death? That is cytomegalovirus. Coming on to the next one, and that is pyroptosis. Again, let's try and break it. Is it also a kind of a cell death where there is some programming like apoptosis, necroptosis? Yes. But what is the element of pyro? So we'll divide it. Pyro is going to refer to fever, pyrogen, pyrogenic. So there's an element of fever. And tosis over here is going to mean some kind of cell death. So I'm making 2 promises with you. At the end of this pathway, number 1, I will teach you that fever will happen in the patient. Number 2, I will teach you death will happen in the patient. So when I'm saying fever, this means this is associated with some microorganism. Why is this cell death going to happen? It is associated with a microorganism, and for what it was studied initially was Shigella and Salmonella. It was actually studied for Shigella and Salmonella. So let's start reading it. So let's take these examples, otherwise any bacteria can cause it. So let me talk about Shigella and Salmonella. This yellow color thing is some bacteria, Shigella, okay? When it enters into your body, what is going to happen? Now remember, I'm drawing one cell over here. This is the cell. So whenever any bacteria enters into your body, which is the receptor which can activate it, or which is the receptor which can receive it? So when this bacteria enters into my body, there is a receptor over here which is going to receive it, and that receptor is known as the nod receptor. That is PYQ, question number 1. In pyroptosis, which is the receptor involved? Options will be toll-like receptor, nod receptor. So remember, nod receptor is the option that you're going to consider. Having said that, please remember that because of activation of nod receptor, now there is activation of a molecule called inflammasome, which is kind of easy to understand. If someone asks you that where are you going to study inflammasome, inflammation will always come with bacteria, right? So inflammasome formation will always occur in the microorganism wala pathway, that is the pyroptosis. Okay, moving on, because of this inflammasome, what is next going to be the case? This activates, now this is where the update has come. This activates caspase 1, 4, 5, 11. The old edition of Robbins used to mention just 1 and 11, but now the new edition says 1, 4, 5, 11. So please remember that caspase 1, 4, 5, 11 are activated, but I had to fulfill 2 promises. Do you know all of these caspases, especially these 4, 5, 11, what do? They are the ones which are going to kill your cell. They are the ones which are going to cause cell death. On the other hand, caspase 1, this is the hero. So cell death promise I have fulfilled, right? Cell death promise I have fulfilled. The fever promise is left. You know, 1 for 1. Caspase 1 activates IL-1. Caspase 1 activates interleukin 1, and that interleukin 1, which everyone knows, causes fever. Have I fulfilled the second promise also? Let's do a rapid revision, because that is the end of pyroptosis. In one slide you finished it. So pyro word means that I'm talking about fever. Which is the caspase that caused fever? 1 for 1. Caspase 1 activated interleukin 1, and that caused fever. What about the cell death part? So the other caspases 4, 5, 11, they are responsible for the cell death. Even 1 can cause cell death, but lesser amount. Okay, which is the receptor to which it is going to bind once a bacteria enters? It is the nod receptor. And what is activated? Inflammasome. That marks the end of pyroptosis also. There's one tiny little cell death which you also have to know, and that is anoikis, which is my favorite because it's just about a single sentence that you'll understand anoikis in. So first and foremost, remember A for A. Anoikis is basically a type of an apoptosis. Anoikis is basically a type of apoptosis. And what do I mean by that situation? So apoptosis means all of that programming and all is going to happen. But why is it different? Why is it just not a regular apoptosis? Because this is basically seen due to a lack of natural environment. And I'll give you a very relatable example so that you never forget. Tell me something, guys. If now all of us have been through the pandemic, the COVID, the quarantine, the isolations and whatnot. So tell me, if I keep you in a group of your family and your friends and your loved ones, you're going to be very happy, isn't it? But if I keep you in quarantine and if I tell you to stay all alone by yourself, obviously there is an element of sadness that is going to come into your life after some time. Same goes with the cells. If I keep the cells in their natural environment, all the friends and family living together, the cell is going to survive. If I take this cell out and I take it away from its natural environment, the cell is going to die. So what kind of a cell death is anoikis? Anoikis is the lack of natural environment. The most relatable cell death that we have studied out of it, right? There's another cell death that is known as pheroptosis. Now, we're not studying pheroptosis in this section. We are studying it right at the end of this chapter because ferro word means iron. So for that, I will first have to teach you the entire iron pathway and then I'll teach you pheroptosis also. But yeah, that is also a kind of a cell death. Having said that, before we end these cell deaths, let's quickly practice 2 questions. Question number 1, which of the following is incorrect about necroptosis? So they've asked me the incorrect statement. So basically, let's do a true-false about necroptosis. First one, is it a caspase-independent programmed cell death? Yes, I feel it is definitely a caspase-independent programmed cell death. Next question, are a RIP1, RIP3 complex is formed, of course, that is very important. Receptor interacting protein is formed. Next, caspase 8 is required. Didn't I tell you, like I was trying to act very strict, that necroptosis word comes and you cannot use the word caspase. So that is obviously the false statement. Caspase 8 is not needed. The pro form can be there. The pro caspase 8 form can definitely be used, right? Coming to the last one, does growth plate formation follow necroptosis? Of course, that's the physiological type of necroptosis. So what is the false statement, guys? The incorrect statement that they asked me is option number 3. Caspase word cannot be used. Let's practice one more question about pyroptosis. What do I have over here? Which of the following is incorrect about pyroptosis? So when I say incorrect, these are the words you have to read very carefully in the exam, right? Because we make maximum silly errors and mistakes are made here. Okay, so let's talk about again true and false. Is it seen in response to Shigella? Of course, it is seen with microorganisms, Shigella, Salmonella, and so on. So yeah, that is correct. TLRs are used. Are toll-like receptor used? As far as I remember, I was again and again telling you that it's the NOD receptor which is going to be used. So I found my false statement, but I'll still read all the options. Is caspase 1 required and is 1 going to activate interleukin 1? Of course, these are true. 1 for 1 is what I was reading again and again. So what is the incorrect statement that we have over here? Incorrect statement is going to be option number B, and that is the toll-like receptor, because toll-like receptor is not used, NOD-like receptor is used. That marks the end of our newer cell deaths: necroptosis, pyroptosis, a element of ferroptosis, and also anoikis. The next topic that you need to know is cell injury is going to be the cellular adaptations. So let's begin with the next topic in cell injury, and that is cellular adaptations. Now first, the very first thing that I taught you in this chapter is that before all your reversible and irreversible cell injuries start, the body first and foremost will always try to adapt to the situation, right? So how many types of cellular adaptations are known? Hypertrophy, hyperplasia, atrophy, metaplasia, dysplasia. Now let me tell you, in this particular chapter, you limit yourself to these 4. Why is that so? Why are we not going to study dysplasia over here? Because dysplasia is nothing but pre-cancer. Dysplasia is nothing but pre-cancer. So obviously dysplasia will be studied in the cancer chapter, in the neoplasia chapter. Right now we are studying hypertrophy, hyperplasia, atrophy and metaplasia. So let's begin with the first 2, which are one of the most important ones, that is hypertrophy and hyperplasia. First, let me show you a schematic diagram. So for example, you have a healthy cell over here, and how many cells can you see? I can see a total of 3 cells over here, right? Okay, so now what would I say about hypertrophy? Hypertrophy means that you can see over here that the cells are still 3 in number, but they've become big and fat. So basically, when the size of the cell is increasing, that is when I call it hypertrophy. Whereas look at the next situation. Now the cells are the same size, but how many number have they gone into? From 3 they've gone to 5. So when I say there's an increase in the number of the cell, that is when I call it plasia. So remember, hypertrophy, like a trophy, you hold a trophy and you obviously feel very proud and big. So hypertrophy is like holding a trophy and becoming only big in size. Whereas when I use the word plasia, plasia word means there's an increase in the number. Having said that, now you are first going to write all of this down and know a little bit about the mechanism, because these are also 2 very famous questions that you have. So first and foremost, we have something called hypertrophy, and I want to differentiate it from hyperplasia, and everything that I'm telling you in this slide is a PYQ by default, so everything has to be known. So first and foremost, what is hypertrophy? Hypertrophy is going to be an increase in the size of the cells. What is hyperplasia? It's an increase in the number of the cells. So next they will ask you, how is this going to happen? Or what is the mechanism that we have? So please remember, if I want to increase the size of the cells, I will have to increase the central dogma. Do you remember central dogma from your basics in school and also in biochem? So I'll quickly write it down for you. What was central dogma? DNA changes to RNA and RNA changes to proteins, correct? Okay. So now they say that if you want the cells to become big, you will have to increase their protein amount. How should I increase their protein amount? For that, I will have to increase the RNA amount. How do I increase the RNA amount? Means more and more conversion will have to happen. more and more conversion will happen. What is DNA to RNA known as? DNA to RNA is known as transcription. So do you agree that if I want more and more RNA to form, I will need an increase in the transcription factors? So if the transcription factors increase, more and more RNA will form. If more and more RNA will form, more protein means more size. So ultimately, we analyze that the mechanism is an increase in the transcription factors. And the question that comes in the paper is, which transcription factors are being considered? So remember, we have GATA4, NF-AT, and MEF2. You don't have to know their full forms, of course, but you just need to learn their names. GATA4, NF-AT, and MEF2. These are the transcription factors that are being elevated, as a result of which more transcription, more RNA means I have more protein, and that is how the size increases. Versus, how does the number increase? How is hyperplasia going to happen? If this is one cell, it is going to form 2. From 2 cells, there is going to be formation of 4. So from 4, there will be 8, 8 to 16, 16 to 32. So basically, I can say by cell division, mitosis. Division or mitosis is how the number is going to increase. But how is the size going to increase? That is the main question, by the increase in the transcription factors. Now, having said that, let's do examples. There will always be examples which are common. First, let me deal with the common examples. So please remember, when you're dealing with these two, that is when you're dealing with hypertrophy and hyperplasia, what are the examples that are going to show you both? And that is where maximum, as I said, questions come. So please remember, whenever they are talking about a gravid uterus, whenever they talk about a gravid uterus, or in other words, a pregnant uterus, they will say it shows you hypertrophy plus hyperplasia combination. Versus if they talk about breast. Now, breast development happens in phases, right? So right now I'm taking the phase of how breast developed during the puberty and what changes in the breast happen during pregnancy. These are two very important events in the development of breast, puberty and pregnancy. So in these also, please remember, both hypertrophy and hyperplasia is going to occur. So what's the confusion? The confusion is that if the examiner gives me an option of both, I will select both in gravid uterus also. I will select both in pregnant and puberty breast also. But if examiner tells me to select one, that is where it is important. So for gravid uterus, hypertrophy is the element which is more common. Whereas when I'm talking about breast development in P for puberty and P for pregnancy, that is where P for plasia is going to be more common. So now just read your question carefully. In both these scenarios, if you have a both option, go for both. But in gravid uterus, if you have to select one, it is trophy. And for PPP, for puberty and pregnant breast, you will select more of P for plasia. These were the common examples. Now I'm going to go on to individual examples, means the situations in which I am going to see only and only hypertrophy. So first and foremost, the most relatable one is going to be bodybuilders. So bodybuilders, of course, the skeletal muscle bulk that they have. So there is going to be skeletal muscle hypertrophy, number one. Number two, please remember, whenever there is any obstruction, so in the textbooks when you sit down to read, it is written proximal to obstruction. So it becomes a little difficult to understand what is the examiner actually saying. So I'll explain it with some diagrams. So for example, this is a urinary bladder. How should I cause an obstruction? Let me put a stone over here. Let me put a stone over here. Okay, so this is a urinary bladder, and urinary bladder has a stone which has caused obstruction. Similarly, let me take the example of an intestine. How should I cause obstruction in the intestine? Let us make a cancer over here. Let us make a malignancy or a cancer over here. So yes, this is a cancer growth that has occurred in the intestine. So in both situations, random situations, have I got an obstruction? Yes. How will the body adapt? So how will the urine pass? The urine is unable to pass. How will the urinary bladder adapt? So proximal to obstruction, how will the body adapt? Here also, proximal to obstruction, the fecal matter can't go out. How will the body adapt? So like I said, proximal to obstruction, the body is going to adapt by hypertrophy, means at this part of the urinary bladder, hypertrophy will happen. At this part of the intestine, hypertrophy will happen. So that is how you learn it, that whenever there's an obstruction, above the obstruction, there is going to be a hypertrophy. And that in a way tells me one more thing. Has everyone heard that whenever there is aortic stenosis, so who pumps blood into the aorta via the aortic valve? The left ventricle, right? So now if there's an obstruction, the aortic valve has undergone stenosis, can it result in left ventricular hypertrophy? Again, if this is the aortic valve has undergone stenosis. This was the open valve, it has undergone stenosis. So what will happen above it, proximal to the obstruction? Hypertrophy. Left ventricular hypertrophy can occur. Having said that, these were examples of hypertrophy only, because now I'm going to tell you what are the examples of hyperplasia only. And that is one for females, one for males, as easy as that. So what do we have for females? There is something called endometrial hyperplasia. Endometrial hyperplasia. And which hormone is responsible for it? I think everyone knows E for E. So whenever there's an elevation of estrogen, estrogen is going to result in something known as endometrial hyperplasia. Does the story end here? No. First question to you is, name one condition which they give you in the paper a lot where estrogen increases. So I'm going to give you one very basic but a very, very important example out here. Have you all heard that there is an ovarian tumor? There is an ovarian tumor which is known as granulosa cell tumor. So remember, granulosa cell tumor, where is the tumor occurring? The tumor is occurring in the ovary. But what is it doing? This tumor produces too much of estrogen. So from the ovary, so for example, if I draw this as the uterus and this is the ovarian mass, this is the granulosa cell tumor, it is producing too much of estrogen. What will that estrogen do? That estrogen will come and do what in the endometrium? It will make the endometrium too much, hyperplastic, endometrial hyperplasia. So can I say, they will always give you a granulosa cell tumor history. If they want to give you a granulosa cell tumor history, compare it with your gynecology. At what age group does granulosa cell tumor occur? It occurs in I've always learned granulosa usually occurs in grannies. Okay, so grannies means this is going to occur in a post-menopausal female, right? So they'll give you a post-menopausal 55, 57-year-old female, and suddenly that female has too much of endometrium. Do you expect a 57-year-old female to have endometrial hyperplasia? No. So why is she having endometrial hyperplasia? Because she actually has a tumor where? Actually her tumor is in the ovary and that tumor is releasing estrogen. That is causing endometrial hyperplasia. Okay, so that happens to be a very good, a very good example. But what beyond it? Because of this endometrial hyperplasia, if I don't treat this female or just any female of endometrial hyperplasia, is there going to be a risk of endometrial cancer? Of course, there is a risk involved of endometrial cancer type 1. In a short while, I'll also teach you type 2 and I'll tell you the differences. But yes, if you don't treat hyperplasia, it's going to result in cancer. That is one thing. So this was the example I wanted to tell you for females. What is the example that I want to tell you for males? So like in females, there's endometrial hyperplasia. In males, there is what you call as BPH, benign prostatic hyperplasia, but that term has changed. Now we don't call it benign prostatic hyperplasia. Now we call it nodular hyperplasia of the prostate. Now we call it nodular hyperplasia of the prostate. So remember guys, firstly, if now repeat with me, if endometrial hyperplasia happened because of E for E, that is estrogen, prostate hyperplasia is going to happen because of what? And most students answer testosterone. Catch over here, and that's not the case. Testosterone purely does not cause nodular hyperplasia of the prostate. Testosterone is going to change into a metabolite called DHT, that is dihydrotestosterone, DHT, and it is DHT that causes the hyperplasia. So once a question came in the paper that hyperplasia is caused in the prostate by testosterone, which was option A, and many students marked it. Option B was DHT, which was the correct answer. So remember, it is dihydrotestosterone which is going to be responsible for this hyperplasia. So who makes it? What is the enzyme? It is 5-alpha reductase type 2. It is 5-alpha reductase type 2. So that is how the conversion happens. So now go into a pharmacology aspect. How are you going to inhibit 5-alpha reductase type 2? There's a drug for it, and that drug is known as finasteride. So finasteride is what is the inhibitor of 5-alpha reductase type 2, and that's how you treat it. So simple, 2 examples, one for female, one for males. For females, endometrial hyperplasia, E for D because of estrogen. For males, nodular hyperplasia prostate, which is because of what? Which hormone? Dihydrotestosterone. Okay, so till now I was talking about 2 things. I've spoken about either the cell size is going to increase, hypertrophy, or the cell number will increase, hyperplasia. Now everything has to go down. What is the third thing that we'll be talking about where everything goes down, and that is atrophy. So when someone asks you what is the definition of atrophy, it's a decrease in the size and the decrease in the number of the cells. So it's decrease of everything. And how did that happen? If the mechanism of action is asked, remember it is by the UPP, that is the ubiquitin proteasome pathway. Ubiquitin proteasome pathway is responsible for atrophy. So now we'll have to understand atrophy with the help of few examples. I'll start with the most day-to-day life example that you can think of, and that is going to be disuse atrophy. So if you stop using an organ, it will decrease. Let's take an example. Most of us have had a fracture once or twice, maybe even more in our lifetime. Or you've obviously dealt with patients or relatives or family, friends and everyone around you. You've always seen someone having a fracture. It's a very common thing. The symbol that we use for a fracture, it's not the hashtag that the Gen Z would want, but yeah, that's the symbol that we have for a fracture. So someone has a fracture of the, say, right leg. What would you do? You would put a cast. So whenever there's a fracture, we put a cast, usually for 6 weeks, but depending on the patient and the type of the fracture, the cast, let's assume 6 weeks. Okay, but why did you put a cast for 6 weeks? You wanted the bone should remain intact like this. The bone should join. The broken pieces, they should not move around. The broken pieces should join back. They should remain intact, right? So you happen to do that, and very well you got good results. The bone pieces, broken pieces joined back, but in 6 weeks, the muscle around it also did not move. So if you've put a cast for 6 weeks, the muscle has stopped moving. Muscle is not being used. It is going to result in muscle atrophy. So that is what I told you, that if you stop using a particular organ for a very long time, like the cast the leg was like this. So if you stop using that for a very long time, this is going to result in muscle atrophy. So that is why, guys, when your cast is removed, what do you tell the patient? Go for physiotherapy sessions. The bone will also become stronger. Your muscles will also gain their strength. So muscles will also become stronger. Okay, this was one thing. Second is, what if you cut the nerve supply to a particular organ? That is denervation atrophy. If you cut the nerve supply to a particular organ, then this is very commonly seen, for example, not common, but yeah, one very good example for this is polio. In polio also, it is the anterior horn and the cells which are damaged. Basically, the neuronal cells are damaged. That is why there is atrophy. So if the nerves are affected, again, the size of the organ decreases. Similarly, if the blood supply is affected, if the blood supply is going to be affected, you will call it ischemic atrophy. And this is the kind of atrophy that happens in old age. So if they say in old age, and also if they say in old age, what happens? In old age, many people suffer from Alzheimer's disease. So if they ask you that in Alzheimer's, the brain, why is the brain undergoing atrophy? Because somewhere the blood supply is being hampered. In old age, in Alzheimer's disease, when the blood supply is hampered, that is when ischemic atrophy occurs. Next, if the person is not consuming good food, if nutrition is not there, then also there is going to be atrophy. Okay, coming to the fifth one, which I would want we should analyze it separately, is what is endometrial atrophy, because now this endometrium is coming in too many places. So now remember, did I just teach you endometrial hyperplasia, endometrium becoming too much because of which hormone? When too much of estrogen was there, too much of endometrium was forming. Now I'm saying that when there is less of estrogen, the endometrium is going to go down. So if I want to write it down, forget atrophy. If I want to do a final correlation of it, you are saying that when the estrogen levels are more, what is going to happen to the endometrium? To the endometrium, there is endometrial hyperplasia. Okay. Similarly, when the estrogen levels are down, what is going to happen to the endometrium? There is endometrial atrophy. Why am I comparing these two? Because both of them are problematic. You don't treat a patient of endometrial hyperplasia, she will land up with what? She will land up with endometrial cancer type 1. You don't treat a patient in this scenario of endometrial atrophy, she will also land up with endometrial cancer, and that is going to be type 2. Obviously, this is not the only pathway. There are a lot of genetic mutations involved in both of them. But have you studied this in gynecology? Endometrial cancer is of two types, endometrial cancer type 1 and endometrial cancer type 2. So type 1 is arising from a hyperplastic endometrium. Type 2 is arising from an atrophic endometrium, which has the worst prognosis. So remember, endometrial cancer type 2 is going to have a worse prognosis. It is going to have a worse prognosis. Well, having said that, so ultimately I realized the female genital tract is very complicated. The more is also going to create a problem, the hyperplasia, the less is also going to create a problem, that is atrophy. So you're somewhere stuck with both places. Having said that, now what do we have? The last kind of cell death or cell adaptation that you have, but the most important, and that is metaplasia. Now guys, please remember, the first word that comes in everyone's mind and the first question that comes in the examiner's mind is metaplasia is 100% reversible. And as soon as I will say this, what will come to your mind? What about the others? What about hypertrophy? What about hyperplasia? What about atrophy? Were they reversible? So let me first clear that confusion. Please remember guys, that all the cellular adaptations that I am teaching you, all the cellular, and I'm writing it in as bold letters as possible so that you have no confusion from any other source. All cellular adaptations are reversible. So please remember, be it hypertrophy, hyperplasia, obviously the cell number can go down if the stimulus is decreased or if the cells die, but all of them at some level are reversible. But I would say the toughest to revert, is atrophy. So the toughest to revert is atrophy, which we just now studied. So let me tell you, if they give you 4 options, hypertrophy, hyperplasia, atrophy, metaplasia, and they say which of them is not reversible, you have to select one, that which of them cannot be reverted, atrophy will be your best answer. But if you read the textbooks, ultimately they say all the cellular adaptations are reversible. Most difficult one to revert, toughest to revert, atrophy. Now with that concept, I can start with metaplasia. So like I said, the first question that will come in examiner's mind is metaplasia is always reversible. So what is metaplasia? Changing, adapting. Basically, metaplasia is all of us adapting all the time. Metaplasia is like a doctor. You have to adapt and you have to. There's no option. You have to adapt from one pattern to another. And if the pattern changes back, you have to come back also. So whatever is happening, you have to adapt. So metaplasia is what? When one tissue is changing into another tissue. And I've not drawn any arrows between it, because look at the arrow that I'll draw. I'm going to draw a reversible arrow, because at any point of time, whatever has changed from one place to another can come back. So this is a 100% reversible, as many times as you can repeat it. Reversible, reversible, reversible. Many a times this question comes, okay? So now why did I say tissue? Tissue could be so many things. Tissue could be an epithelium, it could be mesenchymal, yes. So either I can have epithelial to epithelial kind of conversion, like squamous epithelium becomes columnar epithelium, or any one epithelium becomes another epithelium. Or I can have a mesenchymal tissue converting into another mesenchymal tissue. So muscle is changing into bone. All these are muscle, bone, cartilage. These are mesenchymes. And yes, the arrow between them will always be the reversible arrow. So one either epithelium to epithelium or mesenchymal to mesenchymal. So the question coming in everyone's mind is, what is the mechanism of action? Because we've done mechanism of everything, right? So what is the mechanism of this also that is happening? And it's a very famous question. It is reprogramming of the stem cells. Learn it as it is. There should not be any change that you're doing in this sentence. Remember, reprogramming of the stem cells. I think everyone knows what are stem cells. I'm sure you're very aware of it. Stem cell can make everything in your body. But you know, we've given little bit of training, little bit of tuition classes we have given to stem cell, that okay, you are a stem cell for squamous epithelium. So listen, I've caught hold of one stem cell and I've told the stem cell, you are always going to make squamous epithelium. So that stem cell is always making squamous epithelium. Now I'm going to change. Like we come with updates and we tell you now the answer has changed. Same way, I'm going to now do a reprogramming. I'm going to give tuitions again to the stem cell and tell the stem cell that listen, till now you were making squamous epithelium, okay, but ab ek update hai. Now there's an update. Now you're not going to make squamous epithelium. From tomorrow you will start making columnar epithelium. So have I done retuitioning? Have I done repeat in coaching classes of the stem cells? Exactly what I've done. So why does this sudden change happen? Because I've changed the tuition and the updates given to the stem cell. Having said that, let's understand that with some examples. The first set of examples that I'm going to start with are the epithelial to epithelial. So, if someone asks you which is the most common metaplasia that we have, and your answer is squamous metaplasia. So, your answer is going to be squamous metaplasia. So, let's understand, and you'll also get to know how did I name it. So, let me take the example of the lungs. Now tell me, what is the epithelium of the lungs which everyone is very well aware of? It is the pseudostratified ciliated columnar epithelium. Going back to your first year, right? Pseudostratified ciliated columnar epithelium. So in other words, I have an epithelium with a lot of cilia. But what if? What if I am now dealing with a person who is a chronic smoker? Everyone knows that smoking is going to damage the epithelial lining, right? So what if someone is a chronic smoker? Point number one. What if someone is going to have vitamin A deficiency or vitamin A excess? Both are a problem. Vitamin A deficiency is also a problem. Vitamin A excess. So vitamin A has to be within normal, only then the epithelium remains normal. Less is also a problem. Excess is also a problem. You know what happens in these people? Either someone is a smoker or someone having a vitamin A problem, and this epithelium changes into squamous epithelium. So now guys, has first and foremost, has one epithelium changed into another epithelium? Yes. So do you want to call it metaplasia? Of course. But why did you call it squamous? What did this tell you? How are you doing the terminology? Based on the starting point or the ending point? I am doing the terminology based on the ending point, and that is the squamous is in the end. So as we always say in life, no matter what you do, end result matters. End mein kya hua, kya bana. So end result matters, that is squamous epithelium. So remember, whatever is going to be the end result, that is going to be the terminology. That is why I called it squamous metaplasia. That is example number one. That is also the most common example that we have. But now I'm going to tell you example number two. And that is the example that students believe is the most common, but is not. But students love it. And that's the example of Barrett's esophagus. That's the example of Barrett's esophagus. So let me tell you, let me first draw an esophagus for all of us. So you will now tell me a little bit more of anatomy and histology. What is the normal lining of an esophagus? The normal lining of an esophagus is the squamous epithelium. Now just imagine someone is suffering from a disease called GERD. What is GERD? Gastroesophageal reflux disease. Means what? Reflux is happening from the stomach. Stomach has a lot of acid, right? All the acid is coming into the esophagus. Big problem. All the acid has started coming into the esophagus. So will the lining, acid is obviously very dangerous. Will the lining change? Of course, there's going to be a change in the lining, and that now becomes something known as intestinal columnar epithelium. So now I could have just made it columnar epithelium. Was there any reason that I added the word intestinal out here? What is the purpose of adding intestinal? That is because intestinal cells are very rich in something known as goblet cells, and that is the hallmark of Barrett's esophagus. Why is God giving goblet cells? Any reason? You are adapting. God is making you adapt. Must be for a reason. See guys, there is so much of acid that is coming. You need something to neutralize the acid. So these goblet goblet cells will make something that the acid pH will become normal, and these goblet cells basically make something called acidic mucin. Don't go by the word that already acid was there, why are you making acidic mucin? No, that doesn't mean that this is a kind of an acid, it's a mucin only. Acidic is because when pathologist tests for it in the laboratory, he has to maintain an acidic pH. So acidic word is added because of pathology lab tests. Otherwise, mucin is just mucin. It has no acidic pH, but we call it acidic mucin because of the testing performed. So what does goblet cell release? Goblet cell releases acidic mucin, and you will now ask me, what is the special stain for acidic mucin? Remember A for A. The special stain for acidic mucin is going to be Alcian blue positive. So repeating, the acidic mucin is going to be Alcian blue positive. Repeating once again, what is the normal lining of the esophagus? It's squamous epithelium. But when too much of acid started coming in, what did it change into? Intestinal columnar epithelium. What does intestinal columnar epithelium have? Goblet cells. What do they release? They release acidic mucin. What is the special stain? A for A, that is Alcian blue is the special stain. Let me show you a picture out here. So if you divide this photo like the way I have, the top epithelium is the normal epithelium of the esophagus, that is squamous epithelium. But suddenly, when I look at it below, I realize it has changed into something with cells. Can you see these empty cells? These empty cells are the goblet cells. Why did we call them goblet? Because they look like a goblet of wine. A goblet containing some nice drink. So they are like goblets are wine glasses, or goblets are glasses for some fluid, for some drink. So yeah, they contain which fluid? They don't contain wine, of course, they contain acidic mucin. And these goblet cells are said to be the hallmark of Barrett's esophagus. Remember, they will ask you this question if a pathology question comes on Barrett's. What is the hallmark of Barrett's esophagus? It is going to be the goblet cells. Okay, coming back, let me show you one more picture. These are beautiful goblet cells. If they say there is a biopsy that has been done from the esophagus, there is an esophageal biopsy done, and you can see the presence of these goblet-like cells. Otherwise, in esophagus, I will not see goblet cells. Goblet cells are a very intestine thing. Why am I seeing it in the esophagus? Because somewhere we have ended up having a case of Barrett's esophagus. That is why I'm seeing goblet cells. But why am I studying this in so much of detail? What is so dangerous about Barrett's esophagus? Barrett's esophagus is precancerous. Barrett's esophagus is a precancerous condition. It is going to result in cancer. And which cancer am I talking about? Adenocarcinoma of the esophagus. It is going to result in adenocarcinoma of the esophagus. I hope everyone's clear with it. Very, very important. But again, it is your favorite, but it is not the most common. What was the most common metaplasia? The lungs wala, the squamous metaplasia was the most common. But do you realize till now, I'm only saying ciliated to squamous epithelium. In Barrett's, I said squamous to intestinal columnar epithelium. I'm only focusing on the epithelium changes, because the next and the last question that comes is, where do you see mesenchymal metaplasia? So now I can't talk about epithelia, I have to talk about mesenchyme. And one very famous example for this is myositis ossificans. And you don't have to learn anything, just look at the word, guys. Just look at the word. What is the meaning of myo? Yes, myo means muscle, right? So there is going to be a muscle. And what do you mean by ossificans, ossification, bone formation? So something to do with calcium and something to do with bone formation is going to occur. So in simple words, muscle changes to bone. Very rare thing to happen. Why would that happen? This occurs due to trauma. Remember, this is going to occur due to trauma. So imagine they will give you a history. There's a patient who's had trauma to, say, the right leg or the right thigh. There's a trauma, some accident, some bike accident, someone hit him, some kind of trauma to the right thigh that happened. So after 4 weeks or 5 weeks, he said that in the thigh, he's noticing that there is a nodule which is very, very hard. So you get an X-ray done, and that X-ray is showing you all white, something like a bone. So he is giving you a history of trauma, and in the area of muscle, you started seeing something which is very bony. So what would your diagnosis be? It's going to be a myositis ossificans. And obviously, it's no epithelium. I'm dealing with what? I'm dealing with muscle and bone. It's all mesenchymal. So what is your answer? Mesenchymal metaplasia. Now, before we end this, so we've done what? Hypertrophy, hyperplasia, atrophy, metaplasia, all of them are done. But now I'm going to tell you one particular organ where everything can be seen. It's quite an interesting one, and that is breast. Breast can show you hypertrophy, hyperplasia, atrophy, metaplasia. How? Did I teach you that when there is breast development happening during puberty and pregnancy? During puberty and pregnancy, did we study that both hypertrophy and hyperplasia is possible? But what was more common? Did we study P for plasia, P for puberty, P for pregnancy? So plasia was definitely more common, but ideally both could have occurred. This much information we already know. When will atrophy of the breast occur? Obviously in old age. In postmenopausal females, there is going to be an atrophy of the breast that will occur. Where does metaplasia occur? This is actually a very important surgery question. So please note, metaplasia of the breast is a condition known as SMLD or SMOLD. What is SMLD or SMOLD? It stands for squamous metaplasia. So where is squamous metaplasia? Of the lactiferous ducts. Squamous metaplasia of the lactiferous ducts is what you're seeing out here. So that is what you called as SMLD. Let's repeat. Squamous metaplasia of the lactiferous ducts. So you'll ask me, why does this happen and in whom does it happen? This is most commonly seen in women who are smokers. So to tell you this kind of condition, they will always give you a chronic smoker female. That has to be a history given. So you, till the time she's smoking, this will happen, and once she stops smoking, because I know metaplasia by definition is 100% reversible. Once she stops smoking, it's gonna come back, right? So remember SMLD, squamous metaplasia of the lactiferous duct, seen in smoker females, which makes me realize that breast is capable of undergoing any kind of cellular adaptation. That is how God has designed it. Okay, that brings us to the end of cellular adaptations, which means we are ready for some questions. All are true for metaplasia except another true-false question. All are true except. Okay, so first, is metaplasia slow growth? Of course, it's going to take time. Is it reversible? Yes, of course, 100% reversible. Is it irreversible? That word cannot be used. Of course, this is wrong. Metaplasia is 100% reversible. Last one, can it be precancerous? Of course, we have studied Barrett's esophagus is precancerous. That is true. So, which of the following are true except means which was the wrong statement? Option C is the wrong statement. That is irreversible. Coming to the next question. Histopathological difference between Barrett's epithelium and gastric mucosa. Now guys, please note, when I say Barrett's epithelium, what is coming to your mind? Barrett's esophagus. Which epithelium? Make your answer first. Which epithelium was formed? Intestinal columnar. Intestinal columnar means we had presence of goblet cells. Which mucin was goblet cell producing? It was producing acidic mucin. And what is the stain for acidic mucin that I told you? It is Alcian blue. You've made your answer. Try to search for that answer. Which mucin? Are you dealing with alkaline mucin? No. Are you dealing with neutral mucin? No. Again, are you dealing with alkaline mucin? No. What are you dealing with? I am dealing with acidic mucin. And what should be the stain? The stain should be Alcian blue. So option number A is so right. So like I said, sometimes you don't have to read all the options. You actually have to go upon and talk about options which you have in your mind. Your answer should be there and you have to find that answer. So option A, Barrett's mucosa is acidic and Alcian blue positive. Let's pick up another and the last question of this series, where it's a lengthy question, much in pattern with the next. There's a 47-year-old man who visits the outpatient clinic with complaints of heartburn and chest pain. For the past 6 months, are we somewhere getting a history of gastroesophageal reflux disease? There's a retrosternal pain, heart pain, and it is associated with intake of solid foods, but now it has occurred with liquids as well. So now he's not even able to consume solids or liquids. Antacids do not relieve his pain anymore. He's worried about the pain as it is getting worse and worse with time, and he's also complaining of an unintentional weight loss of 2.7 kilos. Physical examination shows abdominal examination is normal. Hemoglobin is definitely low but manageable. Platelet count is 1,68,000. Anything above 1,50,000 is normal. So platelet count is normal. Esophagogastroduodenoscopy means a proper endoscopy is done, which shows what? exophytic mass in the lower third of the esophagus. So if this is the esophagus and then the stomach, there is a mass that is present over here, which is obviously, mass is obviously a cancer. Now, which cancer? So first, it cannot be an ulcer. Ulcer will never be a mass. Leiomyoma, it's benign. Benign is not going to come to me like an exophytic mass. This is looking something like a cancer. So either it is a squamous cell carcinoma or an adenocarcinoma. So for those who studied the esophagus chapter and surgery earlier, you anyway know that in the lower third, the most common cancer is the adenocarcinoma. But for those who have not studied, you could still have analyzed this question because your patient started off with GERD. If your patient started off with GERD, that is reflux, means first your patient had Barrett's esophagus. And if Barrett's esophagus has occurred, which is the cancer that occurs following Barrett's esophagus? It is adenocarcinoma. So sometimes it's not necessary that you should have studied all the clinical chapters. If you have a good hold over your general path, you are still prepared for solving all the clinical questions. That marks an end to the cellular adaptations. One left, that is dysplasia, which I've told you will be covered into the neoplasia chapter.